My name is Dr. Andrea McKee. I'm the Chairman of Radiation Oncology at Leahy Hospital and Medical Center, and I'm here today to speak on shared decision-making in CT lung cancer screening. I'm also the co-director of the CT lung screening program at Leahy Hospital and Medical Center and subcommittee chair for the CT lung screening group for the Department of Public Health. I have no disclosures. So, defining the problem for lung cancer. Lung cancer, unfortunately, is the #1 cancer killer in the United States, claiming more lives of American women than does breast, ovarian, and uterine cancers combined. This is a major public health problem. And one of the reasons is that in the absence of screening for lung cancer, unfortunately, most of the time we detect lung cancer in the latest stage of disease, stage 3 or 4. Unfortunately, the prognosis of a patient with stage 4 lung cancer is very poor, with less than 1% of individuals surviving at 5 years. Even when we find lung cancer by accident, this is an incidental finding on a chest x-ray that you see before you of a patient with what we call a stage T1B N0 lung cancer. This is a fairly large lesion, as you can see here, a little over 3 centimeters. This person has about a 58% 5-year overall survival. Contrast that to when we're looking for lung cancer. Here's a case of a patient who's actually undergoing CT lung screening, where a 7-millimeter nodule is detected on the baseline CT exam. This would indicate a 6-month follow-up to see whether or not the lesion grows. At 6 months, a 9-millimeter lung cancer was detected. The patient underwent surgery, leading to a T1A N0 screen-detected lung cancer. This patient's 5-year overall survival is nearly 90%. So a dramatic difference in what we can accomplish by diagnosing early-stage lung cancer in completely asymptomatic patients versus late-stage lung cancer, which occurs 70 to 80% of the time in the absence of lung screening. And we find stage 1 lung cancer 70 to 85% of the time in a screened population. So you can imagine this is a game changer. We're about to see significant advances in the 5-year overall survival for patients with lung cancer and significantly reduce mortality. So this is the trial that actually led to the evidence that CT lung screening can save lives, the National Lung Screening Trial. It was one of the largest secondary prevention trials that we have conducted in the United States. It cost $250 million, and it involved over 33 participating sites across the US. There were 54,000 patients in this trial. That is a big study. They were enrolled between the years of 2002 and 2004. Individuals were between the ages of 55 and 74, and they had at least a 30-pack year history of tobacco use, meaning they smoked at least 1 pack per day for at least 30 years, or 2 packs per day for 15 years. Just take the number of packs, multiply it by the number of years smoked, that gives you your pack years. They either currently smoke or quit within the past 15 years. There were 2 arms. One was an annual chest x-ray, so it didn't even compare to our usual standard of care at that time, which was no screening, but they felt that they wouldn't be able to accrue patients to a trial with no screening versus a CT lung exam, so the trial designers elected to compare chest x-ray versus a CT lung exam over 3 rounds. So it was 2 years with 3 rounds, baseline, then year 1, then year 2. A positive test was defined as 4 millimeters or greater, solid nodule that was non-calcified, and other findings that were suspicious for lung cancer were also included, meaning adenopathy in the chest or pleural effusion. The workup was actually determined by the primary care physicians with some direction by the radiologist, but there was no specific algorithm prescribed by the National Lung Screening Trial on how to manage those 4-millimeter nodules. The study was halted early due to a 20% mortality benefit at 6 years of follow-up, or even before 6 years. So remember, this is 2 years of screening followed by 6 years of no screening, and just at that point looking to see what the study demonstrated. They found a 20% lung cancer-specific mortality benefit and a 6.6% reduction in overall mortality. So that was 1,877 deaths in the low-dose CT arm versus 2,000 deaths in the arm with the chest x-ray group. And those individuals were contacted to see whether or not they would like to switch over for the low-dose CT exam once the study was halted. The study showed a 1% overall risk of lung cancer in this high-risk population, with an annual incidence of 0.5 to 0.8%, meaning on the second year of screening, we still find new lung cancers in these patients. And I'm going to show you some of the data when we go out even additional years. In other words, this is the rate at which these high-risk individuals develop lung cancer. It's not just detected on the prevalence screen. Small cell lung cancer is not typically detected at an earlier stage. This is really meant to detect non-small cell lung cancer. And the number needed to screen is 320, meaning you need to screen 320 individuals to save one life. Compare that to breast screening, where it's merely more like 1,000 in one. The number needed to screen is more like 1,000. So this is actually a very high rate of lives saved for numbers screened. Furthermore, there was about a 24% rate of positive findings. Now remember, the study defined a positive nodule as 4 millimeters. And when you do that, in the first round of screening, about 27% of the time, you will find a 4 millimeter or greater nodule. And then by the second year of screening, that decreases to 16.8%. What we've done since then is we've enacted systems to define a positive nodule as a higher threshold. So ACR LungRads is a system that is used across the country to interpret screening exams, and a positive nodule on ACR LungRads is 6 millimeters. So you'll see that the positive rate has gone down considerably in order to make the test more effective. So here we see what's happening in clinical practice. This is data from the Leahy program, where we have screened almost 3,000 individuals. And you can see that the vast majority of screens, this is T0 or the first year, are negative, which is a LungRad 0, 1, or 2. A positive exam, that is a nodule 6 millimeters or greater, occurs at a rate of about 14.5% in the baseline year. But look, it goes down to 8% on year 1 and 4.5% to 5% on the later years. So that positive rate is only on the first round of screening. It goes down considerably over additional years. You see the same thing when a woman enters a mammography program. The first round of screening is going to have more positives. Once you have that baseline for comparison, the positive rate goes down. And that's why it is also very important, if patients have prior CT exams, that the radiologists have access to that in order to try to really make this rate as low as possible of false positives. Suspicious findings, meaning a nodule that is greater than 6 millimeters, which we characterize as a 4A or a 4B, or it has grown over time, occurs in the baseline at around 6%, and then it goes down to roughly 3 to 4% over the additional years of screening. Of those people, however, there's a 40% chance that they have lung cancer. If you have a suspicious LungRads finding, you have a very high likelihood of having lung cancer. So here's the diagnosis of lung cancer amongst this group of patients: 2%, 1%, 0.5%, and then back up to 1% by T3. S positive is the term that we use to define other problems that we may see on a CT lung exam. CT, unlike a mammogram, looks at other things besides the target organ. We're mainly trying to look at the lungs, but we can also see the breast, we can see the heart, we can see the kidneys, and we can see the liver, as well as bones and vessels and other things. So there is a rate of finding something, even though you're not looking for it, when you do a CT lung exam. That rate in the NLST was about 7%. In our program, it was about 8% on the baseline round, but look, it goes down dramatically over additional years of screening, once you have that, again, baseline for future comparison, with an overall rate of 4.3% in our program to date. And what kinds of things do you find? Well, we can find kidney cancer, we can find thyroid cancer, we can find liver cancer. Not that we're looking for it, but this is what we have seen in the patients who do have. This is just of the people who have S positive findings. This is not overall. Esophageal cancer has been detected, adrenal cancer, pancreatic, breast, believe it or not, spine abnormalities, spleen problems, and issues with the aorta like aneurysms. We also make an effort to note coronary artery calcifications. We do not call these S positive or abnormal in our program. Our feeling is if you've smoked cigarettes for over 30 years, 1 pack per day, between the ages of 55 and 80, you're going to have coronary artery calcifications. That's not a surprise. And we find that this very unlikely, actually, 23% have no calcifications versus mild, moderate, and marked calcifications occurring about equally across those three groups. We also make an effort to discuss whether or not the patient has emphysematous changes on the CT lung exam, with no emphysema in about 43%, but again, mild to marked emphysema noted, as you can see here. So some level of coronary artery calcifications is seen in about 88% of individuals. The stage shift is rather remarkable. Remember, when we're screening, we want to diagnose early stage lung cancer. So in our program, about 80% of the time, we're detecting stage 1 lung cancer, and we are significantly reducing the number of late stage lung cancers. Here's stage 4 here. We do also sometimes find limited stage small cell lung cancer and very rarely extensive stage small cell lung cancer. This is a very important slide when you're talking to your patients about CT lung screening. This slide tells you the number of patients who will be found to have a suspicious finding, and of those patients, how many are seen by a pulmonologist, how many undergo a PET CT, how many have a percutaneous biopsy or a bronchoscopy or surgery or any invasive procedure. And then of these patients, how many of them are diagnosed with lung cancer. You can look at the entire population. So this is of all of the people screened. There's a 5% chance that you're going to see a pulmonologist in our program. There's a 2% chance that you're going to have a PET CT. There's a 0.4% chance that you'll have a percutaneous biopsy and a 0.3% chance that you'll have a bronchoscopy with a biopsy. Overall, there's a 0.5% chance that you will have surgery and not have lung cancer. And any intervention is about 1.2%. These numbers compare very favorably to what was seen in the National Lung Screening Trial. So again, only 0.5% of patients enrolled in our program undergo surgery and actually don't have lung cancer. On the basis of the evidence in the National Lung Screening Trial, the USPSTF made a recommendation, a grade B recommendation, that screening should be performed in individuals between the ages of 55 and 80. They actually extended the upper age limit. Remember, the NLST, the upper age limit was 74. CMS went through its own process. Centers for Medicaid and Medicare did a national coverage determination process where they evaluated the data, and they issued a recommendation for coverage in patients between the ages of 55 and 77. So they went up, but not quite up to 80. And this is one of the reasons why there's so much confusion about CT lung screening, is that we have some differing recommendations out there by these large insurers. But in general, USPSTF is currently a mandate that if you qualify for screening, screening is provided with no copay on the basis of that grade B recommendation by the primary insurers or by the private insurers. CMS will cover for Medicare population up to the age of 77. However, CMS requires a shared decision-making visit, integrated smoking cessation, and national registry data collection. So these are the requirements for CT lung screening. We have this cheat sheet, if you will, for our program. This is Group 1, covered by insurance with no copay, and it goes through the different ages and the criteria. We also screen Group 2, which I'm not going to talk about today. These are not covered by insurance. The Group 2 is an equally high-risk group of patients by the National Comprehensive Cancer Network. In our program, we have been screening those individuals, but they do not have insurance coverage at this time. So the shared decision-making visit, it must include a variety of elements, which we're going to talk about now. And documenting what goes into that shared decision-making visit is important. I'm going to give you some cheat sheets on how to document this information as well. So one important thing for you to think about is who actually does the shared decision-making visit in your program. In our program, it is done by primary care physicians, but some programs have a central mechanism where you can refer a high-risk patient into a nurse navigator who will then go over these conversations, perform the shared decision-making visit, and actually order the CT exam. So find out at your center how your program is run, and you will know whether or not you are the one primarily responsible for conducting the shared decision-making discussion. So the key points, you have to define what high risk is to a patient, that 1 out of every 100 patients who are at high risk develop lung cancer. There are ways to look online to make that more specific to the individual, but in general, if they qualify for screening, they have a 1% risk of having lung cancer. You review the natural history of lung cancer and the early detection potential seen in the NLST results that we just discussed. You discuss that this is an annual screen, so patients will need to come back each year because they continue to be at risk for the development of lung cancer, but also the way the radiologist is reporting the exam, the fact that they can call a 5-millimeter nodule benign is based on the fact that they know that that patient is coming back in a year. Otherwise, they would have to say, you need a scan in a year, there's something here that needs to be followed. So know that the radiologists are assuming that the patient is adhering to the recommendation and is coming back in a year in the program. Patient must be asymptomatic. There must be a smoking cessation discussion that occurs with the primary care physician, and then this is the risk and benefit discussion that we're going to review now. The mortality benefit, we've discussed the radiation risk, the risk for overdiagnosis, the risk for false positives, and the association of potential anxiety and how we mitigate that. We use at Lahey a shared decision-making assist in the form of a frequently asked question. So you may not be able to read all this small text, but essentially it goes over in an 8th grade level conversation with the patient about the risks and benefits of screening and questions that they may have. So this is available in every primary care office, and it is given to the patient when they enroll in the screening program. It's 2 pages of information with directions to the patient as to what to do next, but there are other shared decision-making tools online, which I will give you a resource page at the end. Why do some people not perform shared decision-making? What are the barriers to shared decision-making? Time, we know it's very difficult. That's why we try to provide in our program as much support to the primary care physician to do it. Some people feel they already do it. Some physicians say, my patients don't want it. And that may very well be true. Part of shared decision-making is acknowledging when, for whatever reason, sometimes it's cultural, a patient actually wants you to make the decision for them. That's why we feel shared decision-making is most appropriately conducted in the primary care office, where you know the patient's best. You know what the patient has, the decisions they've made in the past, their value system, how they would like to approach something like prevention based on the decisions they've made for prevention in other areas of their life. And so if a patient actually says to you, doctor, I don't know, you tell me, you are participating in shared decision-making, because that's part of it, is knowing that they are giving that authority to you. Lack of organizational support. If a program has not really gotten all of its processes or operational procedures in place, or lack of decision aid. So that's why a well-run program will address these issues and help you at the point of contact with the patient. One of those things includes a best practice alert. This is an example of one in EPIC. When the primary care physician goes to see the patient during an annual visit or otherwise, this alert will come up and say, your patient is at high risk for lung cancer. Please consider a shared decision-making conversation. So helping you to identify those high-risk patients is very important and an important part of what your organization can do for you. The benefits of lung cancer screening we've discussed, and it's important to understand that when we model the annual rate of CT lung screening, that 1 out of 1,000 screened annually for 20 years, there's about 52 lung cancer deaths that are averted. So about 5% of all received in the USPSTF modeling received a benefit. The radiation exposure. Here's an example of what we might see, a nodule right there, when we use a standard CT of the chest, which has about 10 millisieverts. Millisieverts is a measure of radiation associated with it. When we do a low-dose CT, so this is 1 millisievert, it's a fraction of the amount of radiation exposure, you can still see that nodule quite well. And this is one thing this is the reason why we're able to do low-dose CT of the chest, is because the lung fields actually show up quite well, even in the low-dose environment. So low dose means 1 or less millisieverts of radiation. Compare that to mammography, which is typically about 0.7 millisieverts. It's actually a very low dose of radiation. Let's look at some other standard radiation doses. A mammogram is 0.7, lumbar spine films is 2 millisieverts, a diagnostic chest CT is 10 millisieverts, a triphasic CT of the chest, abdomen, pelvis is 25, and background exposure at Colorado is 4.5 versus at sea level is 3 millisieverts per year. Occupational exposure. Me, I'm a radiation oncologist. I work in a radiation department. I can receive 50 millisieverts per year. And a transatlantic flight is 0.1, so 7 times across the Atlantic for an airline pilot is the equivalent of a low-dose CT. So it really is a very low dose of radiation that is used for this program. Keep in mind that it takes between 10 and 30 years for radiation to exposure to develop into a secondary malignancy. These individuals are between the ages of 55 and 80. We're not talking about doing low-dose CT scans to a 12-year-old. This is an older population. The average age is 62 who enroll in this program, and they are at very high risk for the deadliest cancer that we face in the United States. So the radiation risk needs to be put into that context as you discuss this issue with your patients. The risk for overdiagnosis. This is from the National Lung Screening Trial. This is the PATS article, which has been quoted many, many times, and it demonstrates that the risk for overdiagnosis, which means that you diagnose a lung cancer that actually doesn't take the life of that individual, is very, very low. It's about 3% overall when we exclude what we call adenocarcinoma in situ, which are those ground glass opacities, which we do not intervene on unless they start to become aggressive. And that's what your radiologists are meant to advise your program on. So the exclusion of adenocarcinoma in situ results in a 3% risk for overdiagnosis in lung cancer screening. So a summary of the potential harms, a less than 1.5 millisievert radiation exposure, a 12% false positive rate on baseline exam that goes down over time, a less than 0.5% intervention for benign disease, and an estimated 3% risk of overdiagnosis when you exclude adenocarcinoma in situ, which should be done in your program. Smoking cessation. This is the recommended, the 5 A's are the recommended proven form in which we can reduce smoking use in this country. Ask, advise, assess, assist, and arrange. It's important to know that assist means you're providing some counseling or some pharmacotherapy, and arrange means you are arranging for follow-up. We have looked at what using the 5 A's has done in the National Lung Screening Trial. And what this trial demonstrated, was published in JAMA in 2015, is that primary care physicians who used ask, advise, and assess, their interventions were not associated with increased risk rate, quit rates on multivariate analysis. However, when assist, so that is prescribing pharmacotherapy, and arranging for follow-up were employed, the odds of quitting increased considerably to 40 to 46% respectively. So we provide resources at pretty much every possible opportunity within our program. This is an example of our resource page, which is provided to the patients upon entry. It's provided to the patient at the CT module, where we always ask the patient again, even our CT technologists ask the patient, are you currently smoking? Because the radiologist needs to know that information when they're interpreting the exam. And we have published our results. We have a 20.8% prevalence quit rate in our program, which is 2 to 3 times what is seen in the national average. Now remember, these are highly addicted patients between the ages of 55 and 80 who have at least a 30-pack-year history of tobacco use. So achieving a quit rate that is 3 times the national average is a pretty significant accomplishment. You can also see that the relapse rate is about 20% lower than the national average. So patients who have already quit are unlikely in our program to start smoking again as a result of being enrolled in the program. This is an example of a shared decision-making smart phrase that you can use within your EPIC or whatever electronic health record you are using, that you discussed the tobacco cessation plan, that you had counseling that lasted from 3 to 10 minutes. It goes through the shared decision-making, what was discussed, that you used a decision aid, that the patient was counseled on the importance of adherence to the annual screen, and that you did go over the smoking cessation again in written form. Here is the EPIC order, which will have you, again, verify in our program that you've had a shared decision-making conversation as well as smoking cessation counseling. Again, these are requirements by CMS, so they have to be very well documented throughout the chart in the event of a chart audit. These are the billing codes. There is actually a code for shared decision-making in CT lung screening, and I don't know if there are that many other things like that. But CMS did put an actual code in for the work that primary care provides as part of the CT lung screening program to get reimbursed for that work, and this is the code right here that you can bill for. And I would just like to close by saying that in our program, this is all of our lung cancers, not just our screening cases, but we have finally, since I think in 2015, we now diagnose more stage 1 lung cancer than stage 4 lung cancer. And that was not always the case back before we started screening. So we were very, very excited to see that we are finally making a dent, diagnosing early stage lung cancer across our population at Leahy. And these are just some resources to leave you with. These are some links to the AHRQ so that you can look at some of the decision aids as well as some of the information that is out there to help you to go through this process with your patients. These resources are also available on the webinar resource page.